So chapter 24, burns. Burn injuries affect approximately 480,000 Americans each year, and about 3,275 Americans die annually as a direct result of a burn injury. So those are pretty high numbers, I think. About 60% of those clients receive care in burn centers. So they have severe burn injuries. We'll talk about the criteria for a burn center, but the location, the depth, the total body percentage of burned play a role in that criteria. So we're going to focus a lot on assessment and care priorities. So those are the two things to really look at as we go through this burn PowerPoint. So burn injuries are influenced by the temperature of the burning agent and the duration of the contact time. There's different types of burns, so thermal burns, chemical, electrical, radiation. In general, burns are considered preventable. There's a lot of burn prevention programs in place now, and there's been a lot of advances in the past several years. So child-resistant lighters, non-flammable children's clothing, anti-scald devices on tap water, smoke alarms, having battery backup and being hardwired. So there's a lot around burn prevention programs. Your children less than age 4 and our older adults greater than 65, they have the highest risk of mortality from a burn injury. And a lot of times the number one cause of death is hypovolemic shock. So that's going to be our number one focus after airway when we talk about care priorities. So we will be touching on thermal, chemical, smoke inhalation injuries, electrical burns. Frostbite or cold thermal injury is considered a burn injury. We are not going to cover it, but I wanted to just mention that. So a thermal burn is probably what comes to mind when most of us think of a burn injury. So that contact with a hot object. It could definitely be a flame, a flash, a scald burn. A lot of times working on a medical floor during the summer, we would see some increased burn injuries, and any patients that I've cared for with a burn injury, they've been pretty minor, because if you have a significant burn injury, you're going to be directly sent to a burn center. So a lot of clients burning leaves in the backyard, anytime anyone is using an accelerant, clients smoking with oxygen on, campfire injuries. So those are the types of burns that I've had experience with. The amount of time that the individual has had contact with the burning agent, and again, the temperature can impact the severity of the injury. So chemical burns can be contact with acid, alkali, organic compounds. So if you think of a lot of your household cleaners, oven cleaners, fertilizers, the important thing to know with a chemical burn is it can cause systemic toxicity and really cause a lot of complications. A chemical may not be visible, and it still may be present on the skin and continue to cause injury for up to 72 hours. So we'll talk about top priority with chemical burns being prolonged irrigation, removing clothing, brushing off powdered chemicals, things like that. So smoke inhalation injuries, inhaling hot air, steam, or chemicals, smoke from a house fire, the damage to the respiratory tract occurs rapidly, so redness, airway edema. So there is a high mortality rate. You need immediate, rapid assessment and intervention is really crucial for smoke inhalation injuries. We'll talk about metabolic asphyxiation, upper and lower airway injuries. So carbon monoxide poisoning, majority of deaths at fire scenes are a result of inhaling carbon monoxide. When this is inhaled, it displaces oxygen, so the hemoglobin molecules bind with the carbon monoxide, forming carboxyhemoglobinemia, and when levels are greater than 20%, that's when it really becomes critical and can result in death. So these clients are hypoxic. They do not have the oxygenation, but they're not going to present how you would normally see your client with hypoxia. These clients are not going to have the color changes. They're actually going to have a bright red appearance, and you would treat with immediate 100% humidified oxygen. And clients can have a smoke inhalation injury without any evidence of any external burn injuries. So you always want to go back when we talk about assessment and really know the circumstance of the injury, because the rapid assessment and intervention is crucial. So an upper airway injury is going to cause injury to the mouth, upper airway. Rapid swelling can occur. So really looking for clues and knowing the circumstance of the burn injury is so important, because time really matters with any of these inhalation injuries. So you want to look for evidence of soot, singed nasal hair, a client with a hoarse voice, painful swallowing, sputum that has a dark color, any sort of burn injury to the upper chest or clothing. You're going to automatically assume that there's some sort of upper airway injury and be rapidly assessing and performing interventions before you lose the airway. And then with lower airway injury, again, it's not something that you are going to be able to see. A lot of times this is a little bit delayed, so it can happen days, up to 48 hours after a burn injury. Again, you want to be really doing that thorough respiratory assessment, knowing the circumstance of the burn. Clients may need frequent bronchoscopies and supportive respiratory treatment. So electrical burns result from intense heat generated from an electrical current. Electrical currents travel very easily through blood vessels and nerves, and it can cause cardiac complications, severe injury to our renal system, for example, and it can destroy large amounts of tissue, so it can really cause a lot of injury. The amount of voltage, the length of time, the entrance and exit wounds can all play a role in the severity of the electrical burn. So with an electrical burn, there may actually be sparks, and a client may have an electrical burn and a thermal injury. They also may have a further injury if they had a fall related to this electrical shock. They could be at risk for fractures, cervical spine injury. Again, we're very concerned about our cardiac and renal system. With the large tissue injury, which is a lot of times underneath the skin, so it's the extent of it you may not be aware of. That's termed as the iceberg effect. But that large tissue injury really causes a release of myoglobin, which travels to our kidneys and the renal tubules and can cause an acute tubular necrosis, one of our intrarenal causes of acute kidney injury. So that's a really big concern. So classification of burn injury. The American Burn Association classifies burns by the depth. So we'll refer to them as superficial, deep, or full thickness. So a superficial partial thickness, a deep partial thickness, and a full thickness burn. You may still also hear people refer to burns as your traditional first, second, third degree, fourth degree burn, but I'm going to use those depth descriptions to classify the burn injury. The total body surface area, so we will practice with the rule of nines for a quick estimate for total body surface area. So the higher the percentage, the more critical the client is. So for example, anyone with greater than 10% of their total body surface area burned would be referred to a burn center. The location of the burn, so if it's on the upper chest, it's going to be more severe than the lower limb. If there's any, if it's involving the hands or the feet, anything that's going to impact lifelong self-care, those are going to be higher risk locations. If there's an area where there's an increased risk of infection. So location does also play a role. And then patient risk factors. So is there a fracture on top of a burn injury, or are there pre-existing conditions? So is your client diabetic? Chronic alcoholism, drug abuse? Do they have multiple comorbidities? Age? So there's other factors that are going to impact the client with a burn injury. So I just want to go over the cross-section of the skin. This should be a review. So I want to point out how thin the epidermis is. It's about as thick as a sheet of paper. It regenerates every 28 days. The dermis is 40 times thicker than the epidermis. There are some scattered epidermal cells in the upper dermis. So I mentioned that the epidermis can regenerate every 28 days. If you have a superficial burn, then your skin is going to be able, your injury is going to be able to heal and your skin is going to be able to regenerate. As you move into a deep partial thickness or a full thickness, that's where you get into trouble, where you are going to need a skin graft and an artificial source of skin. So within the dermis, I just want to point out there's hair follicles, sweat glands, nerve endings, blood vessels. So the skin plays a major role in as a protective barrier, excretion, sensation, that protection. So I want you to think of that as we're talking about burn injuries, and if the client has loss of those functions of the skin and complications that they might experience. And then the subcutaneous tissue, muscle and bone. So when a client has a full thickness burn, it's not going to be painful. There may be pretty significant pain around the edges of the injury, but that majority of that wound is not going to be painful because the client has suffered injury through the epidermis, dermis, all the way down to the subcutaneous tissue. So I covered these next two slides on the cross-section of the skin. So the total body surface area, there's several different measurements, charts that you can use to do a quick assessment of a total body surface area. The Lund-Browder is actually considered a little bit more accurate because it takes the client's body size into consideration. But the rule of nines is quick. It's a quick estimate, and it's used frequently, so that's what we're going to use as the rule of nines for a quick estimate of total body surface area. So this is an example of the Lund-Browder. Again, we are not using this. You do not have to memorize this one. You do need to know the rule of nines, so I'll let you take a look at this, but I'll just point out a few examples. So the front of each leg is 9%. If it was the entire leg, that would be 18%. Each entire leg is 18%. The front of the trunk would be 18% in the back. Each arm, the entire arm, they would each be 9%, but if it was just the anterior arm, it would be 4.5, or the posterior arm would be 4.5. The front of the face is 4.5, the back of the head is 4.5. The entire head would be 9. So it's all based on nines. So you do need to know that for the exam. So like I mentioned, location of the burn does impact care and recovery. So any injury to the face, neck, and chest, you're really concerned about an airway injury. So high priority. Burns involving hands, feet, joints, eyes, you're concerned about self-care, which can have long-term implications on future function. Burns involving the ears, nose, buttocks, and perineum. The ears and nose have poor blood supply, so they are at a risk for delayed healing. The buttocks and perineum increase risk for infection due to urine, stool, can impact healing. Any sort of circumferential burn can cause problems with blood supply and compartment syndrome. So that really increases the pressure in a certain area. When a client has a burn, let's say all the way around their arm, and you have that eschar and it kind of acts like a tourniquet, and that really requires, that's an emergency, and that's going to require an escharotomy, a surgical incision, to help relieve that eschar and restore that blood flow. So that can cause a lot of problems distal to the injury. And I know I mentioned patient risk factors already, but these can really have a big impact on a client's recovery. So I'll let you read through these because I did mention them already. So I'm going to quickly talk about pre-hospital care, and then we're going to spend most of our time focusing on the emergent phase and the acute phase. So pre-hospital care, definitely you want to remove that person from the source of the burn. Rescuer safety is super important, especially with electrical injuries. Chemical injuries, again, highlight, write in big letters. You really want to brush off any powder, remove clothing, and start immediate water lavage. And that's going to continue for an extended period of time once the client reaches the emergency department, because any invisible chemical that's still present, just remember that can be absorbed and be causing further injury and systemic injury. Small thermal burns you want to cover with a clean, cool, damp towel. Again, remember you're not going to have any sterile supplies or anything like that. So if your patient has a large thermal burn and they're unresponsive, you're going to focus on circulation, airway, and breathing. You can cool the burn for no more than 10 minutes. You definitely never want to apply ice due to vasoconstriction or immerse the area in cool water. Because it's a large thermal burn, clients are having extensive heat loss, and it can cause hypothermia, vasoconstriction. You do want to remove clothing if there's any clothing that is still adhered to the burn injury. You're going to want to leave that in place and just wrap the area in a clean, dry sheet or blanket. If it's an inhalation injury, again, you may not be aware of that, so you really want to look for any clues and find out the circumstance of the burn. 100% humidified oxygen, and you really have to do that rapid assessment and intervention, because we talked about how rapid swelling can occur. So the three phases that we are going to focus on is emergent, acute, and the rehabilitative. Some of these do overlap a little bit, but there's different care priorities depending on which phase your client is in, and that's probably the trickiest part of caring for a burn patient, is prioritizing. So the emergent phase is up to 72 hours post-burn. So I want you to star that. It usually, the patient will be through the emergent phase by 48 hours or so, but it can take up to 72 hours. It's really not going to be past 72 hours. The highest priorities, hypovolemic shock. That's the number one. And with that, there's a lot of fluid shifts and there's a lot of electrolyte shifts. We're also concerned about risk for infection, pain, a lot of other concerns, but the top priorities are hypovolemic shock, this massive edema. We'll talk about what's going on that's causing this hypovolemia, and the fluid and electrolyte shifts. So within 20 minutes post-burn injury, the client has major changes going on to the capillary walls, so increased capillary permeability. Those large albumin proteins are leaking right out of the capillaries into the tissues, causing this shift, this massive shift of fluid into interstitial spaces. So clients are having second spacing, third spacing, fluid in massive edema in areas that they would normally not have any edema. So this results in extreme hypovolemia, and the patient can go into a hypovolemic shock or a burn shock. And I know you talked about shock with Justin. Due to the decreased vascular volume, clients are at risk for thrombosis. There's injured red blood cells due to the burn injury. Clients have that elevated hematocrit, again due to the hypovolemia. So I'm going to let you just kind of look over that previous slide. This slide is also out of your textbook. and this is showing the massive edema post-burn injury, so within 24 hours post-burn. And a lot of times clients might not even recognize their loved one because of this massive edema that occurs. Again, showing the same massive edema after fluid resuscitation. So a lot of fluid and electrolyte shifts are going on. You may see hyper or hypokalemia, hypo or hypernatremia. That inflammatory response occurs very shortly after the burn injury, right at the site of the injury. Within 6 to 12 hours after the injury, the wound starts to try to repair. So these patients are at high risk for infection. They've lost that primary protective barrier, that skin barrier, and then now there's also changes to white blood cells and that immune response, so high risk for infection. So again, we're still in the emergent phase, so these clients have hypovolemia. Again, I'll just run through it quickly. They have increased capillary permeability. Water, sodium, plasma proteins are just leaking right into the interstitial space, bringing all that fluid and protein loss with it. Clients are having second spacing, third spacing, and the body is having a difficult time with just adequate perfusion to vital organs because of this severe hypovolemia. So again, a hypovolemic shock or type of burn shock. The client may also be experiencing blisters if they had deep superficial burn injuries, and they could also be losing more fluid through the blister formation. A paralytic ileus, so that is that loss of bowel sounds temporarily due to decreased perfusion, which may occur in the first 24 hours. Shivering, which causes further heat loss and energy in a client that has large burns, loss of energy in a client that has large burns. And then also a client may have an altered mental status. There may have been some head trauma. They may be sedated, requiring pain medication. So the cardiovascular system, again, clients may have potassium, hypo or hyperkalemia, that's increasing the risk of dysrhythmia. They may have had an electrical burn. We talked quite a bit about hypovolemic shock. A circumferential burn may be impairing circulation to extremities, so a client may have decreased pulse, sensation, paresthesia. So again, that emergency escharotomy, which we'll talk about. Clients have hypovolemia and increased viscosity, increased risk of thromboembolism. So just highlight and start off to the side, again, that this is a circumferential burn of the chest. So you can see how a client would have this tight eschar formation, and then they start to have this rapid fluid shifting and edema that starts 20 minutes post-burn injury. So you can see how that would kind of act as a tourniquet and really impair respiration. So that is really an emergency, a circumferential burn that is having signs of complicating respirations or impairing blood flow, that is an emergency and requires a physician escharotomy, and you can see that incision down the side of the upper extremity and the chest to help loosen that eschar. So we talked quite a bit about the respiratory system, but remember, you may not, the injuries may not be visible, so just really acting early, quick assessment and intervention, and closely monitoring your client. Again, the lower airway injury may be delayed for up to 48 hours. Clients will be at risk for pneumonia due to immobility, pulmonary edema. So clients with a burn injury, they really should have increased urine output. So when we talked about the urinary system, adequate urine output is 0.5 mLs per kilogram per hour. So if you have an adult that's, let's say, 130, 140 pounds, that's approximately 30 mLs per hour. In a burn client, you really want 1 ml per kilogram per hour. So you want to have increased urine output because these clients are having rapid fluid shifts and have increased fluid requirements. Clients are at risk for acute kidney injury with a burn injury. So I want you to think back to your causes of acute kidney injury. We talked about pre-renal, intrarenal, post-renal. These clients would be at risk for a pre-renal acute kidney injury because of the hypovolemia. But they also would be at risk for an intrarenal acute tubular necrosis, cause of acute kidney injury, especially with an electrical burn, where a client has injury to a large area and that release of myoglobin, and again traveling to those renal tubules and causing that acute tubular necrosis. So clients with an upper or lower airway injury may need intubation. Again, that swelling occurs very rapidly. If you're dealing with an escharotomy, a circumferential burn, an escharotomy may be indicated. A client with a lower airway injury may need repeated bronchoscopies. If you're looking at carbon monoxide poisoning, smoke inhalation injury, that immediate 100% humidified oxygen. So aggressive fluid therapy is top priority. So fluid, highest priority for a burn client in the emergent phase, which again, remember, is up to 72 hours post-burn. It could be 24 hours, it could be 48 hours, it could be 72 hours. And you would know that based on your patient assessment. So their vital signs, their urine output, their edema. So clients, you would have 2 large bore IV lines. That sounds easy. That could be very challenging. You could have a client that has a significant percentage of their body burned. So you might be looking at an intraosseous line, an IO, or a central line. The Parkland formula is a formula that takes into consideration the client's weight, their percentage of their body burned, and comes up with a quick estimate of fluid replacement in the first 24 hours. So we're going to practice with that and talk about it in our Collaborate session. So I want you to notice that we're still in the emergent phase. Wound care starts right in the emergent phase. Again, this is a team approach. The client's wounds would be assessed, debridement if possible, and covered, depending on the depth, but the wound would be covered because, again, we're very concerned about infection. If a client had burn injuries to a significant percentage of their body, this may be the cleansing, removing the wounds and having the client in a hydrotherapy cart. The nurse would have PPE on, It would be as sterile as could be because the client is at a high risk for infection. So debridement would occur and then a temporary skin graft to help prevent infection. So an allograft or homograft. They're synthetic or cadaver skin. Right in the emergent phase, you're concerned about positioning, about range of motion. If a client starts to heal, and let's say it's a burn involving a joint, they could develop a contracture. They could be at risk for pressure ulcers. So positioning, splinting, range of motion all happens right in the beginning. Indwelling catheter would be indicated. We're concerned about strict INO. Also, if the burn was to the perineum, we're concerned about infection and healing. You're going to be continually looking at lab values, albumin, prealbumin, renal function, electrolytes, H&H. Clients may be in significant pain depending on the depth of their burn. They may require sedation. Let's say they're intubated. So drug therapy for pain and anxiety. Also, our proton pump inhibitors and H2 antagonists are important for the prevention of gastric ulcers. So that's a very big risk of a complication that we'll talk about. So that started right in the beginning. A burn injury is a major stressor to the body and it can cause a stress ulcer. So star that, that's super important. Every client with a burn injury would just routinely receive a tetanus vaccine. So there's topical agents for the actual burn. So silver sulfadiazine, the brand name would be Silvadene. Yes, you need to know the generic, which is why that's on the slide, but that may sound more familiar to you. It has silver ions, it's antimicrobial, it's very soothing, it promotes infection prevention and healing, so that's used for burn injuries. Mafenide acetate is another topical agent that would be used for an infected burn, and it is painful on application, so you would definitely want to warn your patient that. So these two drugs are important, but that would be used in the presence of an infection. Systemic antibiotic therapy is typically not used unless a client has a sepsis. VTE prophylaxis, so a lot of you have been giving enoxaparin in clinical. This would be pretty standard for our burn injury client. I know you're probably thinking, when is the emergent slides going to stop? This is the last slide of the emergent phase. Nutrition, super important. Once a client has present bowel sounds, nutrition, early nutrition is key for recovery. So clients are in a hypermetabolic state. They need increased calories, they need frequent snacks, they need high protein, they need all of those vitamins that are important to wound healing. So vitamin C, for example, zinc, increased protein, protein powder. They may even need enteral nutrition, protein milkshakes, anything to help increase that nutrition to promote wound healing. So now moving into the acute phase. The acute phase starts when the client stabilizes their fluid status. Now they start to have decreased edema, increased urine output. You're going to see those vital signs stabilizing, so that you're no longer going to have that tachycardia. The pulse is going to return to normal. That hypotension is going to be resolved, and the client's going to have a stable blood pressure. So those are the signs that a client is moving into the acute phase. All of the priorities that we talked about in the emergent phase now kind of shift, and you have different high priorities in the acute phase. So pain might be more of a priority, wound care, nutrition, therapy. You're still monitoring your fluid status, you're still monitoring your electrolytes, but they kind of have stabilized and they've moved to the bottom. The acute phase ends when the wounds have a skin graft or are healing. So skin grafts cannot be applied until all of the eschar is removed. So a deep partial thickness wound may require a skin graft because remember there's only scattered epidermal cells. If it was a superficial burn, the client may not require a skin graft. All full thickness burns would require a permanent skin graft, and that would be once the wounds were debrided. So again, you're still monitoring sodium and potassium. Clients could have hyponatremia or hypernatremia, depending on their course of care after the burn injury. So they could have had excessive GI suction or diarrhea or improper fluid administration, tube feeds. So these could all contribute to alterations in sodium. Just a reminder, symptoms of hyponatremia, weakness, muscle cramps, fatigue, tachycardia. Clients could become confused, have seizure activity as it becomes critical. Potassium, again, clients could have deep muscle injury contributing to hyperkalemia, vomiting, diarrhea, prolonged suctioned, gastric suctioning. So all of these could contribute to hypokalemia or the earlier examples of hyperkalemia. And I know we went over the symptoms of hypo and hyperkalemia. So some complications of the acute phase, definitely infection. We talked quite a bit about that. The cardiovascular system with electrolyte imbalances, electrical burns, different things that we talked about. Respiratory system, if the client has smoke inhalation injury or developed pneumonia. The endocrine system, clients with a burn injury, again, remember it's a huge stressor to the body. So clients will have increased cortisol levels and be at risk for hyperglycemia. So even a client that is not diabetic may actually need insulin therapy for a short time while they're being treated for this burn injury. And then a diabetic may require increased insulin amounts. So just something to think about. Our neurologic system, electrolyte imbalances can cause some neurologic symptoms, so disorientation, seizure activity we talked about. You could have a situation where alcohol or drug abuse was involved prior, and now your client's going through withdrawal and having some hallucinations or perhaps combative, disoriented. It could be an elderly patient that now has a delirium. They are hours away from their family at a burn center with nobody that they know after a traumatic event. So there could be a variety of different neurological complications. Musculoskeletal, again, it could be a client that had a fracture due to a fall, associated with the injury, or it could be, the client had decreased range of motion depending on the location of the burn or development of a contracture. That's why splinting and positioning and range of motion is so important. And then this next one. This is pretty classic with a burn client. They would be at a high risk for development of a Curling's ulcer. This is a gastric ulcer in the presence of stress. So this is a big stressor, a burn injury. So that's why we talked about our H2 antagonists, our proton pump inhibitor therapy to help prevent a gastric ulcer when we went over the drugs for the burn client. So that would be important to know. So wound care, you want to make sure that the room is warm. So you want to increase the temperature in that room. You're going to be thoroughly assessing the wound. The wound may require cleansing. We talked about that. Hydrotherapy cart. Debridement. Again, clients cannot have a skin graft placed until all of the necrotic tissue is removed, so they may require debridement. And then skin graft placement. So a permanent skin graft would be placed once all of the eschar and necrotic tissue is removed. One complication, if a graft develops an accumulation of blood underneath it, that is called a bleb, and a nurse may have to aspirate that. A lot of clients in a burn center, they would have skin cells immediately obtained, and they would be culturing their own skin graft. Or if they had an area that was unburned, they would be taking an autograft, so using the client's own skin. There's a decreased risk of rejection. So pain management is important. In the earlier stages, definitely IV analgesics. As the client progresses through to the later phases, the client may have a long-acting oral and then instant release. So you're really looking at adequate pain control, and then using non-pharmacologic strategies, so visualization, music therapy would just be a few examples. PT and OT start again as early as possible, and that passive and active range of motion, splinting therapy is a big piece of especially this acute phase. So adjusting the calories as your client's wounds heal and their caloric needs decrease. But again, initially, really, they have, in that emergent and majority of the acute phase, they have increased, they need that increased calories, high protein, and you're really going to be closely looking at prealbumin. You want to continue all those vitamin supplements, vitamin C, zinc, vitamin E, all of those dietary supplements, iron. The last phase here, the rehabilitation phase, occurs when the wounds have healed and the patient is engaging in self-care and returning to some sort of normal daily routine. You do want to teach your clients about changes that will be lifelong to the site that they had the burn injury. So the skin is never going to completely recover. They're going to have decreased or increased sensitivity, so they could be at risk for injury. They could have some discomfort to that area. The skin may look different. It may be more sensitive to UV rays damage. So you want to teach your client about using water-based topical agents to keep the area moist and protecting it from sun and injury. So we talked a lot about positioning, splinting, range of motion to minimize the risk of contracture to any area involving the joint. So I'm really hoping to go over a few different things when we do our Collaborate session so that you really get a feel for how traumatic a burn injury is. There could be circumstances involving this injury. This could be a parent that lost their entire family and their home and their job, and so there's a huge amount of loss associated with a burn injury. There's a lot of family stressors, body image concerns. A client could be at a burn center for 6 months. So there's financial stressors. So it's really a team approach. So, and if you're interested in working in a burn center, you would have critical care skills. You would have very rewarding experiences because you really get to develop relationships with these patients. You care for them for an extended period of time. You'll also lose a lot of patients. It might be young patients, patients that you were close with, and families that you developed relationships with. So really self-care and support from each other is really important if you are interested in working in a burn center.